You want to take it in this one? Take it. So when we do any kind of lung ultrasound, we've got three probes that you have. You have the vascular probe, you have the curvilinear probe, and you have the small phased array probe, the very small one, which has got a very small footprint. So you have a large footprint that is curvilinear, you have a small footprint, and you have a vascular probe, what we call as a linear probe. Now the difference between all of these is the frequencies. This frequency is very high. This can go up to 3 to 16 or 11, 12. That's the frequency. The higher the frequency, the lesser the depth. The higher the frequency, the lesser the depth. You understand? So that means to say if I have a vascular structure to be seen, I'll take a higher frequency probe. Okay, this is the vascular probe. So I'm not going to use the vascular probe as of now. You can use it if you want to see the stratosphere sign, the lung pleura. It's quite close. You know, the depth is somewhere around 3 millimeters. You can see up to 3 millimeters in that kind of probe. Okay, that's why you see for vascular, you can see 3 millimeters depth. This probe is a deep probe. See, if you look at the frequency, it's somewhere around 2 to 4. Okay, this is the frequency. It's very low frequency. So that was very high frequency. This is very low frequency. So the internal structures can be seen with these kind of probes. You understand? 2 to 4 and 2 to 5. Now this is a curvilinear probe. We try to use a curvilinear probe for most of our measurements. So the blue protocol will actually involve a patient who's in dyspnea. That is where you use the blue protocol. A blue protocol was invented by David Lichtenstein, was one of the pioneers in radiology, ultrasound, sonography. Okay, he's written books on it. So it's a very simple protocol. In that protocol, what are we going to look at? We first delineate our. So in that blue protocol, the first thing we do is we first search for lung sliding. Patient in dyspnea, what do we do? Patient in dyspnea, what do we do? The first thing we do is search for lung sliding. Okay. So which are the quadrants of the lung that we look at? So this is the sternum. Is a parasternal line. You have the anterior axillary line. You have the posterior axillary line. So you have the. I'll repeat that. This is your sternum. This is your parasternal axis, parasternal line. Okay, parasternal line that is between the sternum and the anterior axillary line. You have the anterior axillary line and you have the posterior axillary line. Okay, this you divide into 4 quadrants in the size of the nipple. So 1, 2, 3, and 4. So it's 1, 2, 3, and 4. So there are 4 quadrants that we look at when you look at patients with dyspnea, right? This can be further. The last quadrant that you have is when you do actually keep my hand this way, keep my second hand this way. So what am I going to do here? I'm keeping it absolutely parallel to the clavicle. I'm keeping my second hand absolutely, and I'm not including my thumb. My thumb is right here. Okay. So now the point that I'm looking at is first here, between my ring finger and my middle finger. The second point that I'm going to look at when I keep my hand this way is in the center of my palm. That's over here. Okay. So when I have my second finger over here, I drop a straight line to the posterior axillary line. That's for at the intersection of the straight line and the posterior axillary line is actually called the Plapp's point. It's called the Plapp's point. So in the event that you have a patient in dyspnea, we need to also see the Plapp's point. So if I want to do the Plapp's point, I'll keep my probe down and then angle it that way. Okay, and then see the deep structures for the pneumonia, right? So this patient is dyspnea. So what I do is I keep my probe on one side of the lung, okay, and what I see now, and when I'm doing my examination for this looking at pleural sliding, for sliding, whatever first thing is sliding. When is dyspnea? Sliding. Yes or no is the answer. Okay, so is this yes or no? To figure out that, it makes a lot of sense to actually keep the gain, to keep the brightness as less as possible, and you can actually visualize the sliding very beautifully, isn't it? You can visualize the sliding very beautifully. So here the backswing appearance, where you have the pleural line here, you have the rib shadows that are coming here, rib shadows here, pleural line here. Okay, obviously when you're looking at it, you're seeing a shimmering that's happening over here. That shimmering is actually the sliding. When I put my M mode down here and then I press M again, what I see now is a seashore sign. Can you see seashore sign? Can you see that? So there are grainy signs. Okay, so when he stops breathing, you get the stratosphere, otherwise it's a green sign. So this is your skin, pleural line, and your seashore sign. What you're seeing is seashore, that means sea and shore, which is delineated by a hyperechoic line, which is the pleural line. Clear? Now we go ahead. So this is lung sliding positive. There is clear lung sliding that you can see over here. Now what we do now is go back to the other slum. Okay, we go to the other side on the same side. And what we're going is going to go to 2D echo now. And here when I come here, I am unable to see any sliding. Let us see. Okay, there is no sliding. If you see, there is absolutely no sliding. What we saw earlier, there is no sliding at all, isn't it? Now, to understand this, this is just his heart, you know. There is nothing else. There is no sliding. Okay, the initial shimmering which was there, we can't see that. So what I'll do now here, so again I go back to the same thing, sliding. This is the pleural line. This is the rib shadows. Okay, and now I'm going to put my M mode here. Okay, put my M mode down here. And I now press M again. Now what you're seeing is a stratosphere. See this? A barcode sign. Can you see that? Can you see that? It's a clear barcode sign. There is no seashore anymore. Since there is no seashore anymore, it's just barcoding, or it is just a stratosphere. This signifies that this particular sliding is absent on this lung. Clear? Clear on this? So now that I know that there is lung sliding that is absent, okay, this can occur in a couple of indications. This can occur in cases where there is going to be pneumothorax, where there is going to be even fibrosis. Okay, if lung sliding was present, what do I do? If lung sliding was present, what do I do? Any idea? What do I do? If lung sliding was present? If lung sliding was present, the next thing I go and I figure out whether there's A profile. Okay, that is A profile means lines, A lines. So if there are A profile and A lines that are coming in, the next thing I do is I look at the DVT. Okay, in A profile, if I look at DVT and there is no DVT, then I'm looking at an airway problem. Simple. I'm looking at bronchospasm as a cause of dyspnea. You understand, no? Clear? So if I get A lines positive, and I get sliding positive, and I get an A profile which is reverberating lines that is coming equidistant from the skin part to the pleura, and from the pleura downwards, I do the DVT. Okay, in DVT, if it is positive, I'm looking at pulmonary embolism. But if DVT is negative, then I'm looking at probably an airway issue, like reactive airway disease. But the other way around, if you have a patient who's coming and I found that there is no lung sliding, and if there is low lung sliding, and I'm seeing I'm seeing a stratosphere sign or things like that, I'm looking at either a fibrosis or a pneumothorax. Now, do you understand whether fibrosis or pneumothorax? Fibroneumotorax, I look at the flaps point. I look at for hyperechoic shadows. I look at air bronchogram. You understand? Now here we may